So again, small pupil and a big problem. So what is small pupil? It depends on various things. It depends on the surgical skill and technique. A good surgeon can do even if they smaller people, but for a novice, a big pupil is a mandatory. Then intraoperative situations like cataract may be soft or cataract may be hard or there may be some complications. So some of the cataracts can be managed with even with a small pupil like softer cataracts, but most of the things require a reasonable size of pupil. Then properties of iris and tissue. There is a iris tissues coming out and it's a floppy iris or something. We require again a bigger tissue, bigger pupil. Coming to the surgical skills and technique, there are various pharmacological agents which has been used to dilate, like tropicamide, cyclopentylate, and NSAIDs. Then we can do viscometriasis with putting a heel on, soft shell technique or disco whisk. Then pupil can be stretched and it sometimes remains dilated. Like elastic pupil, we have to confirm whether it's elastic pupil or it's a rigid pupil. If we try to stretch rigid pupil too much, it may break the sphincters. But elastic pupil can be stretched, the only thing it will come back again. Rigid pupil can be stretched a little bit and it remains there. Then in some cases, sphincterotomy can be done for rigid non-dilated pupil. We can just make a small nicks on the pupil. So that makes the surgery much easy. Then in the Phaco, we have to follow the low fluid parameters and we have to chop the thing. We have to use a vertical chop that makes things much easier. Doing a horizontal chop is difficult in these cases. Restrict manipulation to pupillary area. And bimanual IA helps in these cases. So what are the problem with a small or non-dilatic or poorly dilated pupil? There's a reduced surgical space and we have to make then a small capsular access. There's less visibility of the peripheral of the lens. This causes iris prolapse. There may be retained cortical matter in the peripheral capsular bag which we can't see. There are one haptic of the IL in the capsular bag and other may be in the sulcus. We are not very sure where we have placed it because we can't see it directly. Then there is an increased post-operative inflammation, corneal edema and CME because of too much of manipulation of the iris. So what can be done in these cases? So we have to, before going surgery, we have to remember that any eye can have IFS. There's no telltale sign. So any eye can have IFS, we should be prepared for that. So we should reduce threshold for using pupil expansion devices. We should keep it ready with our OT. And these releases, we have to release the posterior synechia and peripheral membrane completely. Intracameral injection of the combination of mediatics and local anesthetic can be used for these things. Dr. Satanshu, please. Test and distinguish the elastic from non-elastic rigid pupil. Unlike with non-elastic pupil, the IFS pupil immediately snaps back and to its original size following attempt to stretch it. You can't stretch it. So what are the things which we can use during surgery? Iris are very, very popular now and most of us are using already it. So there are some tips once you are using a iris hooks. You can go through as a very small incision like 0.5 millimeter. You can make mark on the limbus before putting the iris hooks. That makes the thing much easier and it can be placed. A hook should be planned well in advance if it is to be placed at the Phaco incision. Then the incision should be limbal. There is a stopper end. Hold the stopper and you can rotate the iris hook to the desired position. And utilizing the tented portion, we just stretch it and slightly it comes out. Then over retraction and asymptomatic retraction the hooks to be avoided. You have to make a symmetric one so the pupil remains dilated throughout and you get an equal area to just expose and don't overstretch it. Otherwise the pupillary sphincter will be damaged and once you finish the surgery, it will not come to back its original position. And you can use even after capsule access, but you have to be very careful, especially in the deep set eyes. And removal is slightly tricky. You have to learn it, how to remove it. Otherwise, if in difficulty, you can take it from the main incision also. Then there are various devices which can expand the pupil. I'll not cover all of them because there is a very long list, but I'll be covering some of this. This is AIOS pupil expander. There's no intraocular manipulation. It's a very fast, easy and safe positioning and removal. Efficient iris expansion. Minimum incision size 1.1 millimeter, that's from the 19 gauge you can put it. It's made from nylon.
The APX is a device designed to mechanically dilate a small pupil. A set of 2 expanders and 2 designated disposable forceps are supplied in a sterile blister package. The forceps tips are inserted through the slit in the base to grasp the outer segments of the APX. The loaded forceps are then locked and placed on the table until needed. 2 19-gauge side port stab incisions are made parallel to the iris plane opposite to each other. A cohesive ophthalmic viscosurgical device is injected to fill the anterior chamber and raise the pupil. The APX device is inserted through the stab incision until the pivot is within the incision. The terminal tips are then positioned behind the iris sphincter one at a time, and the forceps are slowly released until the APX device fully expands. The same procedure is done on the opposite side. Note that no intraocular manipulations are required to position the APX and dilate the pupil. Capsulorhexis and Phaco emulsification are performed in a conventional fashion by direct visualization through the widely dilated pupil. Removal of the APX is done using the same designated forceps in a reverse fashion. The device is simply closed and removed in a matter of a few seconds. Again, please note that no intraocular manipulations are required also for the removal of the APX.
So these are very tiny, and the beauty is you don't require any intraocular manipulation. You don't have to put a second instrument inside the chamber. It's not required. All it is dilating too much. If you feel like you can put another one, but I don't think it's required. Because you got a good square opening there in the pupil. Then there's another device that's the iron pupil expander. This has to be injected come with injector. Basically, the principle is not to cause damage to the sphincter. So these all should be very gentle to the pupil. Now you see it's easy, but only thing you have to put a second instrument, you have to stretch a bit. A very special tip is always just do stretching before putting any expander. Stretch a pupil little bit, then put your expander, not directly stretch. That helps to dilate the pupil properly and you can easily put it. And you have to use a lot of viscoelastic in these to avoid damage to the surrounding structures. So it's made of ring material polyurethane. It's a soft, resilient material that's gentle on the intraocular tissue, and fixed channel height does not compress the pinch iris during the session. It's completely 360-degree engages the iris and eliminates distinct stress point. There's no points as such. And it gives a good 6.3 millimeter circular area to do operation. So it's make the life very easy. Then Maillon ring is probably one of the most popular internationally also. It can go through 2 millimeter incision, that means from the main port, and it's a gentle expansion. There are 8 points of contact. You require a high viscosity, I think that's required for everyone. And Oshoro Maillon ring manipulation is a classic one.
This is Dr. Kachikian from the Eye Institute, and what you're seeing here is the early part of a cataract surgery with a small pupil. The device we are placing here is called a Maillon ring, and we use this ring to expand the pupil to allow us to access the cataract and remove the lens safely. Each eyelet of the ring hooks onto the iris and holds it out of place so we can do the procedure. As you can see here, once we get the last eyelet hooked on the iris is retracted very well, Placing the Malyugin ring in general is minimally traumatic, and removing the ring is fairly easy as well. So it's an excellent solution to a small pupil.
I'll take 1 minute. So this is our Indian version, again an international product, BX pupillary expander. A third generation Bhattacharjee ring. It's a flexible, jointless, hexagonal polymer ring, thin with 6.5 and 0.3 millimeter profile. It's a very thin one, and it has a single plane. You get a 5.5 millimeter pupillary expanded. And now we have got BX 2.0, the newer one, which are big and strong. It slightly thicker, 675 millimeter, and it's good for rigid pupil.
The B-Hex has redefined pupil expansion. Patented uniplanar hexagonal design with notches and flanges. It is 1/10 the thickness of other devices. A 23 gauge forceps advances the preloaded device from its transparent housing through the incision into the eye. As alternate flanges are tucked under the iris, the notches engage the pupil margin, resulting in an expanded pupil. Removal is so much easier than other devices that it can exit even through a 1 millimeter side port incision. And we have a wonderful round pupil at the end of surgery. This is an advantage in femtosecond laser assisted cataract surgery, where it helps maintain a well-formed anterior chamber during docking. The unique advantages are a disruptive uniplanar design, the hexagonal shape, an injector-free delivery system, and a preloaded device in a transparent housing.
I can just sum up that we have capsular hooks also, iris hook also, and we have got the expanded devices. All work well for the beginners. Start with the iris hooks. Once you get it comfortable with them, then try this one, because it requires the intraocular manipulation. Once you are comfortable, you can use pupillary expander. They causes less damage to the pupil compared to the iris hook, and they are now very, very cheap, available in India also. Earlier the cost was a factor. Now it's very cheap, and local products are very, very good. Thank you very much.
Thank you very much, Dr. Vinod, for the wonderful presentation. And now you have so many options of pupil expander available. And but I think still a lot of people use iris hooks, which is more comfortable, reasonable, and cost-wise. And Dr. Vinod, like you spoke all about this expander, do you try to use like ferrocane or pupil dilator first and then go for the expander?
Yeah. Basically, if you use a tropicamide before the procedure, so usually these phenocane or things hardly works. But still, it's better to give a choice to intracameral tropicamide or lignocaine combination.
Yeah.
Sometimes it works in few people, but if you have already used tropicamide earlier, tropicamide plus, so it hardly works in that cases, or those cases.
And secondly, availability of Malyugin ring is now getting a little difficult, because there is some problem with the import of the Malyugin ring now, all over the world.
But now we have got a lot of Indian rings also. There's a Gupta ring, that's again a very good one. Then Bhattacharjee ring is definitely is a very, very good one. I think these all works well, and the cost is not a factor. They cost you around less than 2,000 rupees. So,
Anurag, you be ready with your...
I think
yes, sir, yes.
Anybody can use it. Cost is not a big factor.
Right.
Because you are not using it regularly. It's required in few cases.
Yeah. Take the mic.
Price?
Madhu, iris retractor we know. First, we showed one, first one, that two, I asked the question 3. We can
yeah.
What is the company, what is the price, sir?
It's around 1,600 rupees, Madhu's, Gupta's ring.
Oh, that is Gupta's.
That makes a square pupil, It's a 4-point contact. It's again a very good ring.
It is marketed by Madhu only.
Madhu only.
Newer one. Thank you.
Yes, sir, you wanted to ask something?
Actually, scenario of cataract surgery is very fascinating. The old school of thought that move the digital cataract surgery away from correcting it. I have seen right from the pseudosurgeons who are called as coutures and couching up to the present state. One of the promise of the surgeon is the cataract, which is done by each and everything before the subspecialty. Now, in the pre-surgical area, when there are basically these coutures, they would do the couch, they put together the needle, the limbus, disloding the layers of the patient. That case I have seen in 72 when I was a resident in RP Center. And then came the technique of what you call as the Van Griffiths cataract knife, making a section and removing the lens by ARORA's extra planed first. And then came the technique of removing the lens by erosophagic, erosophagic.
Yeah.
Yes.
And then tumbling, symmetrical technique. Then by syringe.
ECC and then
came by what you call as vectus. Then cryo. Then came the technique of anti-chamber IOL. Post-chamber IOL. Then came Phaco. And still it's going on.
Even femto.
Still the thing is that still we have got a lot of backlog of cataract.
That's right.
And at the far off places, it is done by the eye camps.
That's right. That's right. Thank you, sir.